is a neoplasm of lymphoma is a neoplasm of lymphoid cells. It is a monoclonal proliferation. Some are aggressive, others are indolent, but may transform. If you go back in time, the very early classifications, because we had only histology, were classified into groups determined by cytology and pattern of growth, and we know today that this method is imprecise. For many years now, the approach has been an integrated approach, and this has been the approach to the WHO classification, which has been in existence from 2000, and it relies on integrating morphology, immunophenotype, cell of origin, genetics, and clinical features in order to define disease entities. It includes both lymphomas and leukemias, and it consists of a large number of distinct diseases, each with distinctive epidemiology and etiology. So this is the 5th edition of the WHO classification, which started out in 2022 to 2023, but we hope to have a blue book in the next few months. And this is the list of mature B-cell neoplasms in the 5th edition of the WHO. And you can see this is a long list of entities. And this is a slightly shorter list of mature T-cell and NK cell neoplasms in this classification. So lymphomas, just like any other tumor type, you start out with genetic changes, in other words, the DNA, which is transcribed, so that is the mRNA, and then translated into protein expression, which is the phenotype. And it is this that results in the morphology or the histology that we see under the microscope. So when we see this morphology and histology, we then build up by assessing the phenotype. And this we do by immunophenotyping. Immunophenotyping, as we know, this is a sort of rather basic information, can be either by immunohistochemistry or by flow cytometry. I say and or because these are complementary techniques and not necessarily mutually exclusive in diagnostic practice. So immunohistochemistry has the advantage of the immunoarchitecture. So it gives us an architectural context of the positive cells in relation to the tissue and background populations. And also it highlights which populations are negative for the marker as well. On flow cytometry gives you the added advantage of assessing dual expression and also assessing the intensity of expression, for instance, whether it's bright or dim. And then we add to this by assessing in some cases, not necessarily all cases is this essential, but the genotypic changes and the transcribed mRNA. So we use the DNA and mRNA in assessing molecular genetics and cytogenetics. So the approach to diagnosis has to be that, I mean, if we, as pathologists, if we have to go through this long list each time we get a case in front of us, this would be very tedious. So in our heads, we should have some way of shortlisting possible diagnoses based on histology. So we'll start with histology. And when we evaluate a case, before even we start looking at pathology, we should get as much clinical information as we possibly can. And sometimes, as you know, I mean, this is the problem for pathologists worldwide. I think that clinicians are very, not always very forthcoming when it comes to giving clinical information. And sometimes, depending on what you see under the microscope, you may need to extract more information. But when we assess histology or morphology, we look at now today my emphasis will be mainly nodal. So if you take a lymph node, you have to assess to see, is the architecture preserved or is it effaced? And if it is effaced, is there partial or complete effacement? And we have to also assess to see which compartment is involved and by what cellular infiltrate. So before we look to see whether any tissue is effaced or not, it's quite useful to know what the normal looks like. And this is my diagrammatic or shall we say my attempt at a diagram of a normal reactive lymph node. And I mean, this will be too basic for me to go into this in detail. I know this talk will be available to you after the meeting as well, but this is to highlight the different parts of the lymph node. But this is what you will see under the microscope. You know, it's not all nice and neatly labeled, and it's not always necessarily that it will go through the hilum of the lymph node. So you can see this lymph node, you can see the capsular patency of the capsule, and you can see where the follicles lie. They're mainly subcapsular. Of course, you'll see some follicles cut through depending on at what plane the section has been made. So now we go on to cytology and architecture. So the effacement of normal lymph node architecture, is it effaced or not? And as I said, partial or complete. And then we have to also assess the pattern of growth, because the pattern of growth will tell you quite a lot about what the possible diagnosis will be. But obviously, it doesn't tell you all, just on pattern of growth and cytology, because otherwise the older classifications would have been still applicable. So is it nodular or follicular? Is it a mantle zone pattern? Mantle zone pattern is when you have a naked follicle center, and the infiltrate starts immediately outside the follicle center. So in other words, that's why it's a naked follicle center. And the marginal zone pattern of infiltration is what you're seeing in this image here, where you see a reactive follicle center, a well-demarcated mantle zone, and the infiltrate is outside to that, forming a cuff around the reactive follicle. Then interfollicular paracortical, is it diffuse, or are the sinuses affected? And then you move to the cytological features. Now, the cytological features, is it predominantly small cells, or does the infiltrate have a component of large cells, either present as monotonous infiltrate or sheets of large cells, or are they scattered, well-defined large cells in a background, which is either small lymphocytic or lymphohistiocytic? Or is it polymorphous with scattered neoplastic cells admixed in a background inflammatory process? So in other words, with an inflammatory background. So today's cases will be predominantly small lymphoid cells. So there are two images here. The one on the left has essentially a fairly uniform population of small to medium-sized lymphoid cells, whereas the image on the right has distinct large cells, which actually these are LP cells. Okay, so this is just to tell you what it is, in a background of small lymphocytes. So that wouldn't come under the category that we would assess, saying predominantly small lymphocytes or lymphoid cells. We would put it in this category when we are assessing it, and when we are shortlisting, it will come under this category of scattered large cells in a lymphocytic background. So we won't be touching on the cases like the image on the right, but we'll be focusing on cases which are more like the image on the left, okay, which are predominantly small lymphoid cells. So I don't know how many of you are training pathologists, but if you are sitting an exam, for instance, it's quite useful to be able to quickly construct a table such as this with the immunohistochemical markers, and which markers are positive and negative, which help you to work out what could arrive at the diagnosis based on the immunophenotype. So the differential diagnoses would be chronic lymphocytic leukemia / small lymphocytic lymphoma, mantle cell lymphoma, follicular lymphoma, and if it's in the case of a node, it will be nodal. If it's a primary extranodal, it will be extranodal, marginal zone lymphoma. So we'll come across these differentials and the utility of this table a little later on as well. But now we'll embark on the cases. So this is the first case, a 67-year-old male, right inguinal lymph node excision biopsy. So at this PAR, which is a low PAR, you can see that there is effacement of architecture, you can see in this slide, by a diffuse infiltrate of fairly uniform small lymphoid cells. And if you look a little closely, there are interspersed scattered histiocytes, and these histiocytes don't contain nuclear debris, so they are not tingible body macrophages. And if you look at it even closer, you see that these are fairly uniform to look at, and the nuclei often have this indented or fish mouth appearance. The nucleoli you can see very tiny, so they're essentially inconspicuous. This is another area of this section, and again, you see this population of medium-sized cells with the scattered histiocytes. But there are these areas where there's a well-demarcated sort of spherical areas which contain some large cells, and these are centroblasts, and mixed with some cells which are more irregular, sort of than irregular, the cleaved, I would say. But again, it's not that they look like a different population to the main population that you're seeing here, but size-wise, not very different. So essentially, what you saw there were a naked follicle center, and we'll come to that a little later on. Sometimes it's not that easy to spot. So the morphology of this is a mostly diffuse monotonous infiltrate of small to medium-sized cells with irregular or indented nuclei. There are scattered histiocytes without debris, and there are few residual naked follicle centers amidst the infiltrate. Now, one thing I do want to emphasize, and this is applicable actually in the worldwide setting as well. I'm originally from Sri Lanka, and I did my pathology training, my early pathology training in Sri Lanka. And even in the UK, it is a similar sort of situation where you have lymph nodes, which when they come as whole nodes, and if they're not sliced fresh, you find the center of the lymph node is suboptimally fixed. And if you focus on those central areas, the morphology can be very misleading. The nuclei tend to round up a lot more, and you tend to see nucleoli which look prominent when they actually are not prominent in well-fixed areas. So the morphology can be very misleading. So when you're looking at a lymph node, look at an area where the lymph node is better fixed. So what is the differential diagnosis so far? So the possibilities, so I give you all these possibilities because immunophenotypically, you should really include all possible markers to exclude these. And the reason is because although, if you have excellent morphology and you might be able to have some clue as to what the diagnosis is, but it is always important to exclude other differentials for small B-cell lymphomas. So mantle cell lymphoma should typically consist of a uniform population of small to medium-sized cells with indented or fish mouth type nuclei. They are not admixed with centroblasts, so they are a uniform population of cells, but they tend to have these admixed histiocytes without nuclear debris. So morphologically, this would be really compatible, but it would need immunoconfirmation. So you should never make the diagnosis of mantle cell lymphoma without immunohistochemical confirmation. The other possibility is a follicular lymphoma. Because follicular lymphoma is a mixture of centrocytes and centroblasts, and centrocytes can also have this sort of irregular indented nuclei. Sometimes it is more cleaved, but otherwise, it can resemble the cells of mantle cell lymphoma, but they're mixed with centroblasts. And this sometimes follicular lymphoma can be diffuse. You do get the infrequent cases that can be purely diffuse, but otherwise they tend to be focally, they are follicular, but they can be focally follicular. So nodal marginal zone lymphoma is another possibility. I mean, if the lymph node looks like the image I have given you here, it would be very easy to make the diagnosis because as you can see, there's a very nice pale cuff of infiltrate which is surrounding this reactive follicle with a well-defined mantle zone.
All right.
But unfortunately, there are many nodal marginal zone lymphomas that don't actually look like this because it has overrun the lymph node or the fixation is not very good and you don't necessarily appreciate all of this. So it is very important when you're including this also to keep this at the back of your mind. Then small chronic lymphocytic leukemia and small lymphocytic lymphoma. The cells in this current case have very irregular nuclear contours. So they are indented with fish mouth. Now that appearance is very unusual to see in a CLL/SLL. And I will see a case to come, but they also have an admixture of what you call prolymphocytes and paraimmunoblasts. And, this is not seen in this case. But certainly in some cases, it is not possible, especially in cases where the fixation is not very good. So this would also need to be excluded, and we would include the immunomarkers that are required for this. So we start with the immunohistochemistry. So we use CD20, which is a robust, very robust immunohistochemical marker as a pan-B marker. But just to warn you that there are rare cases of T-cell lymphoma that aberrantly express CD20. So using this as a single marker sometimes can be a problem. And so you should, if possible at all, you should also always use a second pan-B marker, whether it be say CD79A or PAX5. And you can see on this immunohistochemical stain, you can also appreciate the nuclear contours here. You can see that, this irregular nuclear fish mouth appearance that I was talking about earlier. So it's CD3 negative, the infiltrate. CD3 highlights small T cells. The reason I have put the CD5 and CD43 together with the CD3 here is because CD5 and CD43 are normally expressed by T cells. CD43 is expressed by T cells and histiocytes. So when you assess a CD5 of 43, always assess it next to a CD3 so that you can do a mathematical subtraction. And you can see here that the B cells are expressing CD5 and CD43. So that CD5 and CD43 expression is aberrant. CD23 is not, there are some scattered CD23 positive cells, but otherwise the infiltrate is negative for CD23. And what you are seeing is the positivity in the FDC meshworks of these residual follicular structures. So this IgD, I don't expect you to use, but I just thought I'll show you this because it is IgD positive. So the germinal center markers BCL6 and CD10 highlight these germinal centers, which you saw earlier, but they are BCL2 negative, unlike the infiltrate, which is BCL2 positive. So these are highlighting reactive germinal centers, these naked germinal centers that we saw histologically. So this is cyclin D1, and cyclin D1 is positive in the lesional cells, and you can see it coming up in this mantle zone pattern abutting this naked follicle center, which is negative for the marker. And there's another marker which is specific for mantle cell lymphoma, which is SOX11, which is a more recent marker, and this is also positive. P53 is wild type. And LEF1 is normally expressed by T cells, hence these positive cells, but these cells themselves are negative. LEF1 is also a recent marker, and its usefulness is really because in the context, it's fairly specific in the case of low-grade B-cell lymphomas for CLL/SLL. So this is negative. The Ki67 is highlighting those residual reactive germinal centers, but also you see a proliferation index in the lesional cells of approximately 15%. So this is mantle cell lymphoma with a Ki67 proliferation index of approximately 15% and a P53 wild type pattern of expression. So mantle cell lymphoma is a mature B-cell neoplasm derived from the mantle zone. It's composed of small to medium-sized monomorphic cells, and it expresses CD5, cyclin D1, and SOX11, and it's characterized by CCND family rearrangements, most commonly CCND1. So the juxtaposition of CCND1 to the immunoglobulin heavy chain locus results in the 11-14 translocation, which is the genetic hallmark, and it's a primary event. It results in overexpression of cyclin D1. Now, mantle cell lymphoma is uncommon, and it's actually of the small B-cell lymphomas, it accounts for only 10%. There's a male predominance, and it involves lymph nodes, and it can also be disseminated involving the GI tract, where it's referred to as lymphomatoid polyposis. There's also a form of mantle cell lymphoma that, of course, it can involve the bone marrow, the lymph node, the ones which involve the lymph node, but there are also others which are leukemic and involve the bone marrow and spleen, and we'll come to that in a minute. So this is moderately aggressive, despite the fact that it looks histologically low grade, and it's incurable. So the median survival is 3 to 5 years. And unlike other small B-cell lymphomas, there's no transformation to a large B-cell lymphoma, but when it relapses, it may relapse with a more aggressive disease, which may be the blastoid or the pleomorphic variants. So morphologically, the typical or the classic mantle cell lymphoma, it can be nodular, it can have a mantle zone pattern, or it can be a diffuse infiltrate. It's monotonous, this infiltrate of small to medium-sized cells with irregular/indented nuclei. And as we saw, there are scattered histiocytes without debris, so they are not tingible body macrophages. The morphological variants are, so important thing to recognize is the aggressive variants are important because they have a prognostic significance. So the blastoid variant resembles lymphoblasts and have a high mitotic index, so don't misdiagnose this as a lymphoblastic, B lymphoblastic lymphoma leukemia. And the pleomorphic variant essentially has large pleomorphic cells with prominent nucleoli, and if you don't think about it, it may be misdiagnosed as a diffuse large B-cell lymphoma. The other variants are not so useful from a prognostic perspective, but the small cells can be sort of look like mature small cells and can resemble CLL/SLL. And there can be a marginal zone-like pattern with prominent foci where the cells contain more abundant cytoplasm, so imparting a sort of a monocytoid appearance. And this can mimic marginal zone lymphoma, and if they're clustered, you may also confuse it with the proliferation centers of CLL/SLL. So the message is essentially you have to use immunohistochemistry to confirm these diagnoses. There are rare cases of mantle cell lymphoma that are cyclin D1 negative. And in these cases, SOX11 is a very, very useful because we don't necessarily have cyclin D2 or cyclin D3 positive in these cases, readily available for us to assess. Then there's a leukemic non-nodal mantle cell lymphoma. Now, this affects the blood, bone marrow, and spleen without significant lymphadenopathy. And these cells are more like CLL type cells, and these are SOX11 negative and have somatic immunoglobulin hypermutation, in contrast with the nodal mantle cell lymphomas that tend to be naive, so or unmutated. So the CD5 expression may be less common in these cases, and they have a better prognosis than the typical mantle cell lymphoma. So the prognostic factors for mantle cell lymphoma is nodal versus the non-nodal, which I've just spoken about, but also the Ki67 proliferation. So more than 30% is associated with the worst outcome. So this information you should provide to your clinician. And the presence of a TP53 mutation also adversely affects outcome. So the diagnosis, again, is mantle cell lymphoma, and you should give the Ki67 proliferation index and the P53 status. So from this, I move on to the next case, which is a 65-year-old male with an axillary lymph node excision biopsy. So this also has effaced architecture, and even at this far, you can see some pale nodular areas imparting some nodularity to this lesion. And going closer, I mean, obviously, you're seeing some vessels, but what you are seeing is a population of small mature lymphoid cells, but interspersed are scattered larger cells with central nucleoli. And if you look at the paler areas, there is an increase in both the medium-sized and the larger nucleolated cells. So these pale nodule areas, in addition to the small lymphocytes that you are seeing, which I have highlighted here in yellow, you're also seeing medium-sized lymphocytes with a central nucleolus. So this is a prolymphocyte, and also large cells scattered, which have prominent central nucleoli, and these are paraimmunoblasts. So these paler nodule areas are proliferation centers. So morphologically, what we have seen so far is as effaced nodal architecture, infiltrate is vaguely nodular due to these pale nodular areas or proliferation centers. These are not follicles, but if they're pronounced, they can give an impression of pseudofollicular appearance. And the proliferation centers are unique to, I think you know this, chronic lymphocytic leukemia or small lymphocytic lymphoma, which is the non-leukemic counterpart. So again, CD20 is positive. Now, unlike in the flow cytometry where you see a dim CD20, in immunohistochemistry, this is not appreciated. And using another B-cell marker, this is CD79A positive. So again, when we assess CD5, always assess the CD3. In contrast with your mantle cell lymphoma, there are a lot more T cells here, but still, you can see, if you go on, you can see that there is almost two-toning on the CD5. You can see that there's CD5 expression by the B cells as well. CD23 is positive, but you will also notice that CD23 is not uniformly positive. So they tend to be stronger in the prolymphocytes and paraimmunoblasts. And CD43 is strongly and uniformly positive. And unlike in the mantle cell lymphoma, this infiltrate is also positive for LEF1. So cyclin D1 is typically negative, but if you look carefully, you'll see that in the proliferation centers, there's weak positivity in a subset of the proliferation center cells. So this is, you can see it in some cases of CLL, SLL. So this is something that you have to keep in mind and not think that this is mantle cell lymphoma. So MUM1 is positive and stronger in the proliferation centers. And again, you should give a comment on the P53 status by immunohistochemistry. So the positive markers in this are CD20, it's positive for pan B cell markers, it's positive for CD5, CD23, LEF1, CD43, MUM1 in the proliferation centers. Cyclin D1 is negative in most cells, but there's very weak positive in a proportion of the proliferation center cells. So further negative markers, which you have not seen, are CD10, BCL6, which was weak, which is essentially negative, and SOX11 and CD3 you saw. P53 showed a wild type pattern, and there were no underlying FTC meshworks on CD23, which you saw, and also on the CD21 stain. So this diagnosis is quite straightforward. This is CLL/SLL. This is just another case to show you that sometimes this pseudofollicular appearance can be quite striking. And actually on immunohistochemistry, if you didn't see the H&E, you'd wonder whether you're dealing with something like a follicular lymphoma. You know, it gives you the impression that there is nodularity. And CD23, it's the proliferation centers that are strongly positive. You can see the MUM1 in the proliferation centers, which match the Ki67. So CLL-SLL is essentially a neoplasm composed of monomorphic, a small mature. So this is not taking into account the proliferation centers. This is what you see in the blood, really. Mature B cells that co-express CD5 and CD23. It must be a molecular B cell count of at least 5 × 10⁹ per liter with characteristic morphology and phenotype of CLL in the peripheral blood for us to call it CLL. So those with clonal CLL-like count of less than 5 and without lymphadenopathy or organomegaly or other extramedullary disease is referred to as MBL or monoclonal B-cell lymphocytosis. So those with a clonal count of less than 5 but with organomegaly, extramedullary organomegaly, essentially nodal, splenic or other extramedullary involvement is referred to as small lymphocytic lymphoma. So in general, when the diagnosis of CLL is made, it is on the blood. Okay, so sorry, so just a little background. It's the most common leukemia in Western countries, and it would be interesting to know the prevalence and incidence in the sub-Saharan African countries. So it's rare in Asian countries with a low incidence maintained in the immigrant population. There's dramatic increase in the over 70s, and the median diagnosis around that age, and there's a slight male predominance. Most cases, the diagnosis is actually incidental. So the diagnosis is usually made on peripheral blood. So it's characterized also by flow cytometry, and they do molecular genetics also on the blood. And what is a really important thing to assess is the IGH V region mutational status, which also gives a prognostic information, cytogenetic abnormalities, and information on recurrent mutations, which will come to, for instance, TP53. So a bone marrow is performed before commencing treatment, and also if there are any atypical features like an atypical phenotype by flow cytometry, and also once therapy has started to assess response to therapy. So 50% of these are unmutated, whereas the other half are mutated. And the IG mutated cases have a better outcome, as you can see from the median survival of 293 months, as opposed to the unmutated cases, which have a poorer outcome. So on flow cytometry, you are able to assess quite a lot. For instance, you get the phenotype CD5, CD19 is B cell marker, pan-B marker, CD23 and CD43. There's weak CD20 and weak surface IG, and CD20 and CD79B weak, and negative for CD10, negative for FMC7. So so the CLL is scored in this way, depending on marker positivity. And the immunohistochemistry we've already discussed. And also the most common cytogenetic abnormalities are deletion of 13q, trisomy 12, deletion 11q, and deletion 7p. These latter two are associated with a poorer outcome. So next generation sequencing has identified recurrent mutations such as the Notch1, SF3B1, TP53, ATM, and BERK3. Testing for these mutations we know are not widely available, but some of these mutations are associated with inferior response or resistant to certain therapies. For instance, resistant to rituximab is seen in Notch1 mutated CLL. So clinical progression is often associated with increase in proliferative activity. And in the lymph nodes, you see this as the proliferation centers enlarge and coalesce. And these histologically aggressive CLLs have an outcome, not so unsurprisingly, intermediate between the typical CLL and the Richter transformation to diffuse large B-cell lymphoma. So this was an example of a patient, a 58-year-old male, with a CLL diagnosed on co-biopsy, and now there was an enlarged neck node. And these can be quite PET-avid, just to say, these ones which are accelerated. So there is the suspicion that you get is it transformed? And the clinical question obviously was it transformed? So this, although you're seeing quite a number of these nucleolated cells, you can see that this cell composition is a mixture. There are also small lymphocytes, and there are also these intermediate-sized prolymphocytes and paraimmunoblast. So this still has the cell composition of a proliferation center, but they are quite pale because of the increase in cytoplasm in these cases. And this is what you see when you look at it on higher power. So over time, CLL can progress, and in 2 to 8% of cases, they transform and they can develop into a diffuse large B-cell lymphoma, rarely a classic Hodgkin lymphoma. So in a large B-cell lymphoma, they're essentially uniform population of sheet-like uniform population, just like any other diffuse large B-cell lymphoma. Most of these DLBCLs are clonally related to the previous CLL. And if this is the case, the median survival is less than a year, so the prognosis is poor, as opposed to a clonally unrelated DLBCL, which will behave just like a de novo DLBCL, so with a better outcome. So the diagnosis in case 2 is CLL-SLL, and the reason why these cases are biopsied are often incidental finding of a lymphadenopathy when they are assessing the patient for something else, and somehow the clinician has not even bothered sometimes to do a full blood count to see whether there is a, because if there is a raised full blood count, there's lymphocytosis, and the lymphocytosis is due to the CLL, then there's actually no need to do the lymph node biopsy. So the third case is a 71-year-old right inguinal lymph node excision biopsy. So this is looking slightly different now. There are very clear effacement of architecture, what looks like effacement of architecture with by an infiltrate with a follicular growth pattern, and there's a high density of follicular structures. And if you look carefully, this infiltrate is also extending with these follicles, and I'll show you another slide in a minute, into the perinodal fat. So you're seeing these follicles which are extending into perinodal fat, and this is not something that you see in reactive lymph nodes, so something to keep in mind. There is also quite a well-formed mantle zone in these cases. So if you look at another section of this, some of these follicles, I mean, they're not uniform in appearance, they're not small, they're varying in size to some extent, but it's really densely packed. So looking at it a little closer, you can see the follicles. You can see here there's there's a mantle zone here, but you can see the follicles consist largely of centrocytes. They are mainly small cells, and they don't really have tingible body macrophages. So this should alert you into what's going on here. This is not normal follicle. So the question is this follicular lymphoma? Is this reactive follicular hyperplasia? Or is this another histologically low-grade B-cell lymphoma? So let's park the third possibility for a minute and just focus on these two possibilities, follicular lymphoma versus reactive follicular hyperplasia. So if you go back to this case, the sinuses are not patent. It's densely packed with numerous follicles, and this infiltrate is seen to go out into the beyond the capsule. But the mantle zone is well formed. So these three features, which is sinuses not patent, obliteration of sinuses, densely packed numerous follicles infiltrating beyond the capsule, would favor follicular lymphoma because these features do not favor a reactive process. So this was the reactive follicular hyperplasia that I showed you at the start of the talk, and this is on the left is case 3. So you can see the distribution of the follicles in this reactive follicular hyperplasia is very different to this dense infiltrate where the whole lymph node seems to be involved by this follicular process. So if you look at these follicles, as I said, there seems to be there are no tingible body macrophages to be seen, and they seem to be mostly composed of centrocytes. Now compare this to a reactive follicle. So this is a hyperplastic follicle, and you're seeing very nice zonation here, the dark zone with the predominance with centroblasts, where the tingible body macrophages live, and then this is the light zone on this side. Yes, both, of course, have this well-formed mantle zone. So this is quite different from a reactive follicle. So looking at it more closely, you can see, yes, this has a predominance of centrocytes with definitely less than 15 centroblasts in a high power field. So if you compare this with a case of follicular lymphoma, it's another case. So you are seeing a mixture of centrocytes and centroblasts like you're seeing here. So you can see that depending on the fixation, not all follicular lymphomas look alike, but the cell composition is similar. And you can see on the case on the right, you can see also that there are centroblasts. Centroblasts have these peripherally located nuclei, a bit like what a potato looks like with eyes of the potato. And here again, there's a very nice centroblast. These may not be that well preserved, but again, you can see they're peripherally located nucleoli, sorry. So then we also have to consider, so now we are moving away from a reactive follicular hyperplasia to a lymphoma. But what about another histologically low-grade B-cell lymphoma? Let's just keep comparing. So on the left-hand side is our case, and on the right-hand side is a mantle cell lymphoma. And not the case that you saw, but this is another mantle cell lymphoma. And you can see a uniform population of cells. This is an FDC here. This is within a it's a nodular growth pattern where there was an underlying FDC meshwork, and there are some histiocytes. And here you're seeing these are much more cleaved, elongated and cleaved, the centrocytes, and you're seeing these scattered centroblasts. So we saw this mantle zone pattern here, which also is something that you can see in mantle cell lymphoma, but you can see that the proliferation seems to be really outside of this naked germinal center. What about nodal marginal zone? So nodal marginal zone lymphoma, this is that image you saw earlier, slightly smaller. I mean, the problem, as I say, is not all lymphomas read the textbook, you see. So it doesn't always have a textbook image like the one you're seeing here, where if you see the process on the left is mainly a follicular process. The process on the right, you can see, has a marginal zone distribution. And if you look at the follicles, they will be reactive looking follicle centers. But unfortunately, sometimes when the node is completely overrun and fixation is not always great, it can be quite difficult to work out whether, and we'll come to this in a minute, sometimes a nodal marginal zone lymphoma can colonize the follicles and also spread outside to the rest of the nodes. So then can be quite difficult to work out, is this an infiltrate that is actually coming out of the follicle, or is it secondary colonizing? So it's not always that straightforward, and therefore immunohistochemical confirmation is essential. CLL SLL is a little easier if the fixation is decent. So you see this on the left, you can see these centrocytes predominating, but also a mixture of centroblasts, and this is a proliferation center with predominance of these central nucleoli within these prolymphocytes and paraimmunoblasts. So this is quite different in appearance, but nevertheless, as I said, always include the immunohistochemical markers required. So this is the CD20, and the CD20, all it is telling you really is that in addition to highlighting the follicles, there is an infiltrate outside the follicles, which is quite dense. And this is something that you shouldn't really see in a reactive lymph node. Okay, so from this, we move on to the germinal center markers. So this is a CD10. It's positive in the follicular areas, but also you're seeing it in the interfollicular areas, although far fewer. So there's downregulation in the interfollicular area, but nevertheless, there is some positivity, which is not what you really should see in a reactive follicle, where the germinal center B cells should be actually confined to the follicle center. Similarly, BCL6 is prominent in the follicles, but downregulated the interfollicular area. Just to say, in follicular lymphoma, the CD10 and BCL6 are upregulated when there is a FDC, follicular dendritic cell milieu, and is downregulated outside of the follicles where there are no FDC meshworks. And similarly, if you look at a bone marrow involvement by follicular lymphoma, these also would have downregulated BCL6 and CD10, and except by flow, which picks it up. It's not always easy to pick it up on immunohistochemistry on a bone marrow troponin. So BCL2 is positive in the germinal centers. You can see that here very strong. Always compare it with the CD3 and CD3 because T cells are positive for BCL2. So therefore, if you have a follicle which is rich in T cells, it can confuse you. So always do this subtraction story. And of course, this is CD5 negative as well. CD21 and CD23 highlights these FDC meshworks. And the Ki67 is moderate in the follicles and lower in the interfollicular compartment. Contrast this to the reactive follicle centers in case 1, which had those naked germinal centers. But of course, if the centroblasts are, if it's a higher grade follicular lymphoma, the proliferation will be higher. So this is follicular lymphoma grade 1 to 2. The WHO of 2023, the classification does not require you to grade follicular lymphoma grade 1, 2, and 3A. So you can just refer to this as classic follicular lymphoma. But I guess it depends on what your clinician would want. So grading of follicular lymphoma, we know that 1 to 2 is considered low grade, and 1 to 2 should have between up to 15 centroblasts per high power field. And if there are more than 15 centroblasts per high power field, if there are still mixed centrocytes and centroblasts, you call it grade 3A. And grade 3B are solid sheets of centroblasts. Grade 3B in the new WHO classification is referred to as follicular large B-cell lymphoma because it is, as I'll come to it in a minute, it's different from the classic follicular lymphoma, which is grades 1, 2, and 3A. It's more akin to diffuse. Grade 3B is more akin to diffuse large B-cell lymphoma. So grading, these are examples of grade 1 where the centroblasts are less than 5, and this is grade 2. So we don't refer to as grade 1 and grade 2 anymore. It's grade 1 to 2, and this is a 3A where there are more than 15 centroblasts, but there are still centrocytes, and then of course the sheets of large cells which are within the follicle, which is follicular lymphoma grade 3B, which is now called follicular large B-cell lymphoma. So the immunoglobulin B genes show extensive and ongoing somatic hypermutations. So sorry, there's a typo here. In more than 90% of cases of low-grade follicular lymphoma, much less frequently in grade 3B, you have the characteristic rearrangement, which is the 1418 translocation involving the IGH and BCL2 genes. So we know that BCL2 is an anti-apoptotic gene, which has to be switched off in the reactive normal germinal centers. So by this enhancement of BCL2 gene, you get an anti-apoptotic effect, and this is seen particularly in the low-grade follicular lymphomas. So in addition to 1418 by itself is not enough because you can see that in situ follicular neoplasias, you need other genetic alterations in follicular lymphoma to develop overt follicular lymphoma. So as I said, the indolent ones are grades 1, 2, and 3A. 3B is biologically closer to diffuse large B-cell lymphoma than other follicular lymphomas. So the natural history is different from other follicular lymphomas and resembles diffuse large B-cell lymphoma. Up to a third of cases of follicular lymphoma transform to diffuse large B-cell lymphoma, and the transformation is typically associated with additional genetic abnormalities. And if a MYC rearrangement occurs, the combination of MYC and BCL2 can be very aggressive. And these are referred to previously as double hit lymphomas. And now we just refer to it as either a large B-cell lymphoma with MYC and BCL2 rearrangements in the new WHO classification. So this is another example of a follicular lymphoma, just to say that sometimes, now in the one on the left, the follicles are very well defined, and the one on the right, they are less well defined. And you might think, could this be mantle cell lymphoma? Could this be something else? So therefore you have to be very careful. Sometimes if the histology is not very well preserved, you can have diagnostic difficulty. Okay. So this was the example. This is our case, and this is the follicular lymphoma that I just showed you on the right here. Actually, the pathology, the cytology is better preserved in this case when you look on higher power. So diagnosis of case 3 is follicular lymphoma grade 1 to 2, or classic follicular lymphoma. So the last case I'm going to show you is a 55-year-old male, and this time we are moving away from a lymph node. This is a gastric biopsy. So this gastric biopsy, you can see that there's a dense lymphoid infiltrate. There could be some vague nodularity, but essentially it looks diffuse. And what you can see is that it has overrun some of the pre-existing acinas, the crypts. And if you look closely, there's also there's infiltration into these crypts with some eosinophilia of the crypt epithelial cytoplasm. Now, remember that reactive base lymphoid aggregates may be seen, but they are basal and they don't extend up between crypts. In this particular case, the infiltrate is too dense with effacement of architecture and infiltrate extending between glands. So this is not reactive. So this is definitely lymphoma. So the differential diagnosis would be of histologically low-grade B-cell lymphomas. So because the site is gastric, you have to consider an extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue. I'm sorry, there's another typo here. So it's mucosa-associated lymphoid tissue. I'll correct this when I send you the PDF copy. Or Malt lymphoma. Then other small B-cell lymphomas can also involve the stomach, usually as part of disseminated disease. morphologically, CLL/SLL is composed of small mature lymphocytes, which may be mixed with prolymphocytes and paraimmunoblasts, but sometimes, in crushed biopsies and so on, this can be difficult to appreciate. Mantle cell lymphoma, we've discussed this. They're uniform population of medium-sized cell with indented nuclei. Rare subtypes like small cell and marginal zone-like may occur, which can cause confusion, but it has this histiocytes with no debris. The follicular lymphoma is follicular architecture. Occasionally it can be diffuse, and there's a mixture of centrocytes and centroblasts. So extranodal marginal zone lymphoma, you can see a nice marginal zone pattern, but the follicles may be overrun and colonized, and this can be quite difficult then to differentiate. So small lymphocytes, you can see small centrocyte-like cells, you can see medium-sized lymphoid cells with a monocytoid morphology, and a few scattered large cells. So malt lymphoma in epithelial tissues, the neoplastic cells typically infiltrate the epithelium to form what is called lymphoepithelial lesions, recapitulating the normal malt that you see in the small intestine in the Byers patches. So this is, you can see this eosinophilia associated with these lymphoepithelial lesions, which are actually best appreciated by a pancytokeratin. And in this particular example, not in this case that I showed you, this has these monocytoid-looking cells with these almost like fried egg appearance. So if you're lucky, when you make the diagnosis, it'll look like this, where you have a nice follicle center, you have a mantle zone, and you have a nice marginal zone around it. But unfortunately, you're not always that lucky. And what you invariably get is biopsies which look like this. So where the infiltrate has colonized and overrun the pre-existing acquired malt or the acquired mucosa-associated lymphoid tissue from which the tumor has arisen. So the neoplastic cells reside in marginal zones of these reactive follicles, and they extend into the interfollicular regions as well as cause follicular colonization. So you can see how this orange part can actually occupy practically the whole of the tissue. So this is essentially what you're seeing here. You're seeing this extensive, dense infiltrate, which is positive for CD20. And you can see here how it's going up, creeping up between the follicles. And as I said, the lymphoepithelial lesions are better appreciated on the A1, A3. So comparing the CD3 with the CD43, this is expressing CD43. Not all malt lymphomas will express CD43, just to say. And on the CD21, this is something that you tend to see, and this is something which has given rise to this nodularity. So when it colonizes these follicles and sometimes overruns it, there is this disruption and expansion of the underlying follicular structure. And this infiltrate is BCL2 positive, but again, this is not very, this is just to tell you that it is BCL2 positive. But it doesn't help you to differentiate it with any other type of lymphoma. CD10 and BCL6 are negative. And in this case, this is our light chains. And just to tell you, when you interpret light chains, in plasma cells, it is quite easy because you have intracytoplasmic immunoglobulin. But in the small B cells, you have to look for synthesis of the immunoglobulin in the cell. Because immunoglobulins have a low molecular weight, there tends to be a lot of diffusion outside the cell. So if you see something which looks like membrane type positivity, like you're seeing down here, it is probably interstitial staining, which is sticking onto the membrane. So it's non-specific staining. So if you're looking for specific staining, you should look at the perinuclear space, which is where the rough endoplasmic reticulum is and where the synthesis occurs. And this is how it should look. So if you look at these, there is this, I don't know how well you can see it, but this is almost outlining the nucleus, and that is essentially how you should see it. So it's positive for kappa and negative for lambda, so it's kappa light chain restricted. So further immunohistochemistry, which I didn't show you, was that it was negative for cyclin D1, CD5, and CD23. H. pylori was negative, but I've just shown you an example of H. pylori positive case, which is, you can see here, this we use immunohistochemistry. And CD138 highlighted only a few plasma cells. Sometimes, in some cases, this may be prominent. So the immunoprofile positive for PAN-B markers 20 and 79A, CD43, BCL2, and it was kappa restricted. Negative markers were the germinal center markers, cyclin D1, CD5, and CD23. And you saw these expanded and disrupted FTC meshworks, which were seen on the CD21 stain and also on the CD23. So this is this, the the table that I showed you. And so if you look at this malt lymphoma and you look at the immunostains, so CD5 in malt lymphoma is typically negative, but rarely it can be positive. Generally, when it's positive for CD5, it's negative for CD23. So it's negative for CD23. And cyclin D1 and SOX11 will be negative, and it will be negative for the germinal center markers. So CD43 may be positive, like in our case here. And really the use is to differentiate reactive from lymphoid hyperplasia. So when it's very early malt lymphoma, and it's where you have spillage of cells from the base and creeping up, and you see the CD43 positivity in the B cells, that is very helpful. So left one, as we know, will be negative in this case. And also something which is important to recognize that sometimes this is can be very confusing in the lymph node setting. It can also happen in nodal marginal zone lymphoma. Some germinal center markers may be upregulated in the follicles when malt lymphoma shows follicular colonization, but it is not present in the interfollicular areas. So this diagnosis is extranodal marginal zone lymphoma of mucosa-associated lymphoid tissue or malt lymphoma. It is a primary extranodal indolent B-cell lymphoma. Cytoarchitectural features resemble the Byers patch lymphoid tissue, which is a prototypical normal mucosa-associated lymphoid tissue or malt, typically arising in the marginal zone of an acquired malt, often associated with an underlying chronic inflammatory disorder. So as I said earlier, reactive lymphoid hyperplasia needs to be differentiated from early malt lymphoma. So they tend to be basal aggregates, but you can see if there's some spillage in outside, for CD43 can be quite useful. So remember, mantle zone B cells are IgD positive. So if you see an infiltrate which is expressing IgM and negative IgD spilling out from the follicle into the outside of the mantle zone, then that would be useful as well. Light chain restriction is useful, but it is better seen if the plasma cells are neoplastic when you see this abundant intracytoplasmic expression of the light chain. And also, of course, other B-cell lymphomas, as we've discussed. We've gone through this, so I won't go through it again. And the etiology in many malt lymphomas, there's a history of chronic inflammatory process. It's interesting that actually malt lymphoma is very rare in sites of normal malt. So for instance, the ileum, for instance, it's very rare to get a malt lymphoma. So these are acquired malt, like for instance, in the stomach, secondary to Helicobacter gastritis, or salivary malt lymphoma, secondary to Sjögren's syndrome, thyroid malt lymphomas due to Hashimoto's thyroiditis. So the stomach is the most common site, but other sites, conjunctiva, ocular adnexia, skin, lungs, salivary, breast, thyroid can all have malt lymphoma, even soft tissue. The course is indolent and recurrences tend to involve other extranodal sites. And you can have a lung malt, which can also be disseminated into the stomach and so on. So protracted remissions may be induced by antibiotic therapy in the case of Helicobacter positive malt lymphoma, and other sites also, for instance, conjunctival malt, etc. They're not Helicobacter, by the way. And then you have transformation to diffuse large B-cell lymphoma can occur in a small proportion of cases. The diagnosis in this case is extranodal marginal zone lymphoma or mucosa-associated lymphoid tissue or malt lymphoma. So I leave you with this table, which is useful for trainees. And I thank you for your attention, and I'm willing to take any questions.
For the audience. So as Richard said, it's the topic is it's an old favorite. The Hodgkin lymphoma is an entity that has specific features, and it has stood up for centuries now. I'll be talking about Hodgkin lymphoma in general, in basic terms. I have a couple of disclaimers. As mentioned by Richard, I'm not a hematopathologist by specialty. I'm a general pathologist, but I have an interest in hematopathology. You have to know that the subclassification of lymphoma is very dynamic subject and changes every a few years. And our reference, I referred here in this lecture to the WHO book, which gained lots of pages across along the last few years. But please, I urge you to continuously review the literature The talk is based on the WHO. I will mention any differences in the ICC classification as I go. As you know, that there are two groups, but the general terms or the general framework, I believe they are the same between those two groups. I will mention it. And you have to remember that lymphocytes, they don't read books and they don't care about what you think they should like or do. So what we will be saying here is a general terms, general features, but each lymphoma likes to change one or two things of the general things that we see. Usually I start my lectures with describing how a normal lymph node histology will look like. The normal lymph node will have two main areas called the cortex and the medulla, and it has a sinus. They have sinuses. Though the patent sinuses is one of the features of a normal lymph node pathology. An intact capsule without extension of the lymph nodes beyond the capsule is also one of the normal findings. In the cortex, we see some germinal centers, and these germinal centers, so what we call a secondary germinal centers. And then we will see in the mixed population of cells in the interfollicular areas as well as the medulla. And there is also the hilum. Well, the hilum is like highly vascular and shows some fatty tissue. And there is an extensive high endothelial venules within the lymph nodes. Other cells that I didn't mention are the follicular dendritic cells and the interdigiting dendritic cells, which are present also in the cortex and interfollicular areas. So this is what it looks like in the histology. You have a capsule, sometimes well delineated nodules. The thickness of the capsule is dependent on how reactive it is. The long-standing diseases or long-standing processes will have a thicker capsule than just a normal capsule. There will be like a primary follicles as well as secondary follicles. And when we know how we know that it is a reactive germinal center versus a diseased one, we have something called polarity. So one area of the follicle will be darker than the other area with maintained tangible body macrophages. Maintained mantle zone and then and marginal zone as well is a feature that we can see here in these lymph nodes, in these follicles, just to delineate a normal lymph node architecture. The other thing that I wanted to mention is the lymphomas in general. It's basically either a B-cell lymphoma or a T-cell lymphoma, and those are the most common ones. I know that there are other cell types, but the B-cell lymphomas, either the maturation, like the journey of a B-cell comes from the bone marrow and go to the germinal centers of a lymph node, whether but the T cells, like they start in the thymus and they go to the and they will go to the lymph nodes. Then what we will be mentioning is that the Hodgkin lymphoma per se, as I go through, it is considered even in the WHO book under the B-cell lymphomas, and basically like the germinal center type or the germinal cell type lymphomas, and that's why we consider Hodgkin lymphoma it's like a diseased B-cell disease. Again, I won't go into details, but just to know that the markers that we mentioned throughout our throughout our lectures are actually like the either transcription factors or cell membrane receptors that will change along the maturation from the bone marrow to the lymph node or the germinal center, and if you understand how the changes is happening through the lymph node, you will understand which markers are which, and which markers will be positive or negative in any lymph node. The samples that we get in a lymph node, if you are in a service that will receive a hematopathology, you will receive lots of samples, either an FNA cytology, but it's not the best in assessing lymphomas. We're just lacking the architecture that we see in usual lymphoma. There is an EUS guided biopsy that's okay, but it's in between cytology and core biopsy in the quality. The core biopsy is becoming more popular and challenging, and we are seeing it more often in these days. So become familiar with the core biopsies. I think this is it's important, because that will be the what you will be assessing for the next in the next few years. But excisional biopsy will remain the gold standard for these for assessing the lymph node architecture. When we talk about the lymph node core biopsies, it's important to assess the adequacy of the cores, and you can imagine this is just a theoretical core biopsies through the lymph node that I showed you earlier. So if we've taken cytology, we are just sampling multiple tissues from multiple areas of the lymph node. But if we've taken like a core 1 biopsy, for example, we will just be sampling the interfollicular areas only, without much architecture of the follicles to see. If it's a core in core 2 biopsy, if we sample it, it will be like assessed as an interest, or like as an adequate core, because it passes through the capsule, follicular areas, interfollicular areas, and multiple follicles are ideal. But that's why we don't make a huge diagnosis on one core biopsy. Only 2 or more core biopsies are ideal for a full assessment. Example number 3 is inadequate core biopsy that goes through the capsule. So we aim to have more of 1 or 2 of core number 2 likes, so we will gain a good assessment. This is the general map. So if you have a biopsy happening in the lab, you assess it if it's adequate or inadequate. If it's adequate, you see if it's neoplastic or reactive. If it's neoplastic, you will see if there are non-hematolymphoid malignancy, like metastatic disease or a lymphoma. And then the lymphoma, the big umbrella is either Hodgkin or non-Hodgkin lymphoma. And that's what we will be talking about here, like a Hodgkin lymphoma, the classical Hodgkin's lymphoma, or the nodular lymphocyte predominant Hodgkin lymphoma. And as I mentioned before, I based my talk on the WHO, and that's under B-cell neoplasm. And there is a chapter called Hodgkin lymphoma that will include classic Hodgkin's lymphoma and nodular lymphocyte predominant Hodgkin lymphoma. And here it's worth mentioning that the term, so like they are 2 different entities, 2 biologically different diseases. And the nodular lymphocyte predominant Hodgkin lymphoma tend to be a more, the prognosis is better, and the disease survival rate is higher. The staging at the time of diagnosis is lower. So that's why they trying in these days to remove the Hodgkin from the name, and you will be familiar with the name nodular lymphocyte predominant B-cell lymphoma, and that will be used for the maybe will be used in the subsequent WHO, but they kept it as a Hodgkin lymphoma just to keep the research going on and capturing this and avoid any confusion. So just become familiar with this name as an alternative to nodular lymphocyte predominant Hodgkin, as a nodular lymphocyte predominant B-cell lymphoma. And the last thing in the general introduction that I will introduce is the lymphomas. The morphology of the lymphomas are, if you have like a visual mind of what a lymphoma will look like. If you have sheets of small round blue cells, these have specific differential diagnosis of small cell lymphomas. If you have follicles or nodules, either follicular lymphoma or nodular lymphocyte dominant Hodgkin lymphoma. If you have sheets of medium cells, think of mantle or Burkitt's. Sheets of large atypical cells, think of diffuse large B-cell lymphoma, T-cell lymphomas, or anaplastic large cell lymphoma. But this is the pattern that we are after, is the scattered atypical cells in a reactive background. And this is a typical for classic Hodgkin's lymphoma, as well as other entities that we will be mentioning in this disease, in this lecture. So shall we start? And just to let you know, it will be a basic type of approach type of thing, rather than a heavy a clinical or epidemiological background. So I will be like focusing on the practical issues. So we'll start with the classic Hodgkin lymphoma. Classic Hodgkin lymphoma, the general concept, what you have is isolated cells. That's a typical large cell in a background of reactive cells. That's basically it is. And these atypical cells come in multiple forms. The most common one, or it's the Reed-Sternberg cells. And the Reed-Sternberg cells, usually they are 4 or 5 times larger than the smaller lymphocytes nearby. They will have large nuclei. Usually the ideal one has 2 nuclei, but it can have more. And the nucleoli are red and staring at your eye, what we call like an owl eye appearance. So this is the classic picture of Hodgkin Reed-Sternberg cell. But they are not the only cells that you can see in Hodgkin lymphoma. The Hodgkin lymphoma have a Hodgkin cell or mononuclear Hodgkin cell. So similar to the previous one that we have seen, but they are one round cell with one prominent nucleoli, eosinophilic nucleoli. We call it Hodgkin cell. And you have sometimes lacuna cell where you have a surrounding halo around the capsule with some vacuolation of the cytoplasm, forming like a lacunae. Or sometimes you will have these mummified cells which are dense cytoplasm and pycnotic nucleoli. So these are the hallmark, not the hallmark, I will not use hallmark, but these are the typical cells that you see in Hodgkin's lymphoma. So these are the larger atypical cells that you will be looking for. And then the other component is a background. So what you have in the background, you will have mixed population. It differs from different types. Different types have different constituents of the inflammatory cells, but the background is non-neoplastic. But it's important milieu for the developing of Hodgkin's lymphoma, and most cases have a predominance of T cells with variable numbers of eosinophils, as we see here, the pink cells, variable numbers of neutrophils, as well as plasma cells. And histiocytes, plus minus forming granuloma. And that's it. Now you know everything about classic Hodgkin's cell lymphoma morphology, and you can diagnose them safely. The second thing that we wanted to know that is on cytology, it's very hard to identify these cells. And usually we discourage making a diagnosis of Hodgkin's lymphoma on a cytology specimen. It needs high level of suspicion, high level of clinical correlation. However, it might be useful in some cases of relapse disease or diagnosing of a relapse of Hodgkin's lymphoma, where an excisional biopsy or core biopsy might be difficult. So then an FNA can be accepted. This is an example of a case that a smear was more or less sufficient to diagnose a Hodgkin lymphoma. So we can see the smear is moderately cellular, and we can see these large cell populations, some of which mononucleated, but yeah. And the background of these cells in a different core show a mixed population of neutrophils as well as necrosis. So that was easy to make a diagnosis of, and some neutrophils as well. So that made it easy to make a diagnosis on these biopsies. Okay. Now coming to the fun part, the HRS, like the like Hodgkin Reed-Steinberg cells, are the typical immunoprofile that they are usually CD30 positive in the basically all the cells. They CD15 the majority of the cells are positive, but can be focal or patchy. But concurrent CD30 and CD15 expression is highly suggestive of Hodgkin lymphoma. And then the added features are the PAX5. It's a weak DIM. PAX5 is a B cell marker. It's a nuclear marker. So weak or DIM expression is seen in Hodgkin lymphoma, and this is because, as we said before, it's a diseased or a defective B cell neoplasm. So these B cells will be weaker to express B cell markers, and that's why we have variable expression of multiple B cell markers, including CD20 can be positive in patchy cells, but usually they are negative. The other B cell markers that are usually negative are the OCT2, BOB1, BCL6, or PU1. But the OCT2 and BOB1, sometimes they will have a very weak expression in Hodgkin's lymphoma, and we see that. But negative staining will be just a good sign that you are dealing with a classic Hodgkin's lymphoma. The EBV, we will mention that it is associated, different types have a different expression of EBV. GATA3 can be expressed in 80% of cases, PDL1 can be expressed in 40%, and STAT6, we don't usually use it, but it can be expressed in also 70 to 80% of cells. The typical cells of classic Hodgkin's lymphoma are negative for CD45, and the B cell marker CD19, CD79. They don't express the immunoglobulins. They're negative for plasma cell markers and T cell markers. But know that, as I said, they don't read books, so sometimes in 5% of cases, they can express some T cell markers, usually CD2 or CD4 more than CD3. The background population beyond these atypical cells is usually mixed population of T and B cells, depending on the subtype. And usually we see CD21 follicular dendritic meshwork, or dense retained staining, or at least regressed in some focal areas. And this is the typical staining pattern that we see in CD30. So it's a membranous staining, and with a dot within the cytoplasm, what we call it a Golgi pattern type apparatus pattern of staining. And this is also expressed, like CD15 will show a similar expression of cytoplasmic, but sometimes it can have some granular cytoplasmic staining as well as the CD15, but it's uncommon in CD30. And this is the panel that we usually say. So membranous pattern, positive staining for CD30. These larger cells, as we can see here, they are negative for CD20. Typically staining, like the CD45 is negative, and sometimes it's very hard to interpret CD45 because of the density of the background lymphocytes. But you have to see the pattern in multiple cells to identify, for example, in this area here, it's technically negative membranous staining between two cells. This is the weak PAX5. It's so dim or weak PAX5. And if you have a comparison between this and the background dense population or dense staining for B cells. So this is the differential staining. So these are the larger cells, are the weak Reed-Steinberg cells, and the background is the B lymphocytes. And you can see the difference between this pattern of staining. So with a good control, if you have a good working PAX5, you will have that differential staining. CD15, it's and we will mention it. Sometimes it's hard to interpret, especially in mixed cellularity, because all the granulocytes in the background can show positive staining for CD15. So you have to aim for the larger cells. CD3 is negative, usually in the background cells, and this is MUM1 strong positive staining. The other panel, if this is not conclusive or like some of which are not conclusive, like we have to assess the EBV status. Sometimes we do OCT2 and BOB1, and as well as some T cell markers as a panel too. And this is just to emphasize on the point that you need to see what you're looking at. So you have to correlate with the H&E and immunohistochemical stains. So these are the CD peri positive cells. They will be positive for CD15, and all the background rubbish that you see in the CD15, they are not true staining. So you have to correlate that this cell that I'm looking at the same area. This is the cell size, the important cell size, and the pattern of staining, the Golgi pattern of staining as well. So by that, congratulations, you know everything about classic Hodgkin's lymphoma morphology and the immunohistochemical staining, and you're ready to go for the next stage. So what are the histological variants of classic Hodgkin's lymphoma? There are 4 histological variants that we know. In the new WHO book, they mentioned that there is prognostically, they are not significant anymore. They used to have they thought that it has a clinical significance, but now it's not significant as a prognostic relevancy. But however, it's important to know these features because we need to maintain. You need to know your morphological pattern and your differential diagnosis, and to be able to identify different patterns of a disease. And also for the research purposes, like they kept subclassifying these lymphomas depending on their variants to see the clinical significance for later on. So the most common type is what we will mention is the nodular sclerosis type, nodular sclerosis classic Hodgkin's lymphoma. So what we can see typically is thick fibrous bands, ideally hypocellular areas, and then you will have of hypercellularity. And this is the typical picture that you see on core biopsies. Usually they are present as a mediastinal mass. Nodular sclerosis Hodgkin lymphoma is have a predilection for young patients with more female predominance rather than male predominance. And these nodules are the cellular nodules that they will contain some RS cells as well as lacunar cells on a mixed cellularity background, as we mentioned earlier. Eosinophils, histiocytes, and neutrophils are common in this feature. Sometimes the larger cells will form sheets of cells. So this is what we call a syncytial variant, and it's not uncommon in nodular sclerosis Hodgkin lymphoma. The other things that we see in this are the capsular thickening as well as necrosis. So you can see here, this is the same case, a central area of necrosis and then the cellular areas outside. And within these cellular areas, you see the background. Sometimes we refer it to as the dog's breakfast. So it's a very much like a mixed population of multiple types of cells, neutrophils, histiocytes, as well as eosinophils. And you see these scattered larger cells, some of which binucleated, some multinucleated, or mononucleated, as you see here. So this is the typical nodular sclerosis type. We'll move to the other area. It's the mixed cellularity, classic Hodgkin lymphoma. What you see is E-phase architecture with no significant fibrosis. You allow some thin bands only, but you don't have, just thin bands, but not thick fibrous bands. You will see frequent RS cells. There will be mixed background comprising small lymphocytes, histiocytes, eosinophils, and plasma cells. Neutrophils tends to be less common in this subtype. And you will see epithelioid histiocytes or granulomas. It has male more than female predominance and more association with EBV. I'll show an example of mixed cellularity that have histiocyte, eosinophils, and plasma cell as well as lymphocytes. So you can see here from low power, the overall architecture is effaced. So you can't see the follicles, you can see the capsule. Or you can see the capsule, but you can't see the sinuses. They are obliterated. And if you zoom in for any of the areas, you find these cells. The Reed-Sternberg cell, just highlighted by strong positivity for like a very prominent nucleoli, and the background is mixed population of cells. There's lots of histiocytes, lymphocytes, some plasma cells, and isolated eosinophils as well in this. So this is a typical feature of mixed cellularity Hodgkin lymphoma. If we see the CD30, it will highlight most of these larger cell population. And you can see the pattern of staining that we see here. It's like a membranous as Golgi pattern type apparatus pattern of staining. And in this case, it was an EBV positive staining, which confirmed the diagnosis. So that's an EBV Eber-ish positivity. And what you see here is the positivity in the larger cell population. Some small cell population in the background is acceptable, but the larger cell population are the cells that are positive for EBV. And just for comparison, CD15 will be showing this positive staining in the larger cells as well, confirming the diagnosis. All right, so that's the mixed cellularity. And then you will have the lymphocyte-rich classic Hodgkin lymphoma. It can be diffuse, it can be nodular. The hallmark of this is the abundant lymphocytes with no significant neutrophils or eosinophils in the background. So you don't see that mixed population of cells, mostly lymphocytes only. You will have compressed interfollicular areas and regressed germinal center, as you see here in this picture. So you will have these germinal center slightly regressed than normal, and the RS cells within you will find it within those larger nodules. And this one has a differential diagnosis of nodular lymphocyte predominant Hodgkin lymphoma, as we will describe or we mention later. The last variant is the lymphocyte depleted classic Hodgkin lymphoma. Usually have a diffuse growth, but lots of pleomorphic HR cells. And the eosinophils and plasma cells are equally scarce and no significant fibrous bands, but there will be lots of fibrotic background. There is a strong association with EBV and HIV, and it's thought to be a spectrum with mixed cellularity, classic Hodgkin lymphoma, the mixed cellularity, when it loses more cells with more fibrosis, it will become lymphocyte-depleted Hodgkin lymphoma. So congratulations, now you know everything about morphology, immunohistochemistry, and histological variants of classic Hodgkin lymphoma. Now, I will be starting to mention the differential diagnosis list, but let's stop at this stage to see, is there any questions that I can address, or shall I keep going?
Thanks very much, Dr. Hussein. There are some questions. There's one, should we have both CD15 and CD30? What if only one marker is positive? I think you've kind of answered that, but maybe some clarification on that point. Yeah.
So CD30 is it's a must. It has to be positive. But CD15, at least a proportion of the classic Hodgkin lymphoma should be positive for it. And there is a mention of a CD15 negative classic Hodgkin lymphoma, but this is a very rare occurrence, and you have to exclude all other entities before making such a diagnosis.
Yeah. So thank you very much. I agree. We also find PAX5 quite helpful because the Hodgkin cells are almost always weakly positive for PAX5. And the differential staining between the weakly positive Hodgkin cells and the strongly positive infiltrating B cells is often very helpful. The other thing which you mentioned on your slide is that CD45 or leukocyte common antigen is negative in classical Hodgkin lymphoma. And I know you're just about to come on to the differentials, but many of the differentials for classical Hodgkin lymphoma will be positive for leukocyte common antigen. So that also is a good one. CD15, I agree, is often weak, maybe patchy, and sometimes just negative. But see, and yeah. The other question is, what is meant by compressed interfollicular areas? This was in lymphocyte rich. Yeah.
Yeah. So the as you can see here, so it forms like it's basically forming, especially in the nodular variants of this. So the neoplastic cells will be abundant around these residual follicles, and they will expand to regress this normal mantle zone and marginal zone, as well as the interfollicular areas. So we see that the nodules is expanding in the expense of the interfollicular zones. I think that's what I mentioned. I meant.
Thank you. And that's really good. I must admit, I hadn't appreciated the presence of the regressed germinal centers. So that's one thing that I've learned as well. So thanks. We'll let you carry on with the next bit. Hopefully, I'll learn even more. Thank you.
All right. Feel free to comment on anything, Richard. Yeah, you're an expert as well in this field. All right, so we'll go to the differential diagnosis list of classic Hodgkin's lymphoma, and I'm mentioning classic Hodgkin's lymphoma per se because this is what we mentioned, and I will go systematically. I will show examples when I have it. The most common thing that you need to differentiate between, like at Hodgkin's and the T-cell histiocytic rich B-cell lymphoma, they have an overlap mostly with nodular lymphocyte predominant Hodgkin's lymphoma, and we will mention that later on. But it can be a differential diagnosis for mixed cellularity or lymphocyte rich. But as we mentioned earlier, this is considered technically a B-cell lymphoma. So these larger cells should be essentially negative for CD30 and CD15, but positive for CD45, and the cell like B-cell program, all the transcript like PAX5, OCT2, BOB1, and CD20, usually they are very strongly expressed in these cells. Technically speaking, to make this diagnosis, these large neoplastic cells should represent less than 10% of the cell population that you see. And the background, you will have histiocytes as well as small T lymphocytes rather than B lymphocytes, and this is important. We will mention that later on. Other differential diagnosis, and this is very important not to miss, is the infectious mononucleosis. So like this is a relatively treatable disease. It's not a neoplastic process, but it is an EBV associated. However, on the histological level, it can mimic Hodgkin lymphoma. And if you're not aware of it, if you don't think of it, you will easily miss it. Usually the tonsil is a very common location for this, enlarged tonsil in a young population, in a young patient, usually male. What you can see is how you can differentiate between this and Hodgkin lymphoma. There will be less distortion of the overall architecture, and you can still see the follicle, slightly regressed follicles, but you can still see them. However, you can still see necrosis, as well as some fibrosis, but not thick fibrosis. The paracortical expansion will have immunoblasts, and sometimes they can look like HR cells. So these are the cells that you need to differentiate. And the background, there will be small lymphocytes, usually CD8 cells, and some plasma cells. However, how to differentiate? The larger cells in infectious mononucleosis will be CD45 positive. They will be CD20 strongly positive. So these are the main differentiating factors. But be careful that it will be CD30 and either-ish positive. However, CD15 is usually negative in these diseases. And this is just an example to see how these germinal centers are more or less easily identifiable. And you can see how this can mimic a nodular, a lymphocyte-rich classic Hodgkin lymphoma. However, the background population or the interfollicular areas, they don't have the typical RS cells. They're usually large cells with one or multiple prominent nucleoli resembling immunoblasts rather than RS cells. All right. The other differential diagnosis for classic Hodgkin lymphoma is technically a common entity, is a diffuse large B-cell lymphoma with or without EBV positivity. And particularly, I will mention that if the diffuse large B-cell lymphoma have a pleomorphic variant or a pleomorphic or anaplastic variant as well, like with lots of large cells, they will resemble RS cells. The EBV positivity will just add to this confusion with classic Hodgkin's lymphoma. However, how you differentiate between these two entities, there will be no eosinophils, no abundant T cells or rosettes. There will be technically diffuse population of B cells, and the B cell immunophenotype is fully expressed. There will be CD45 positive and CD50 negative. This is an example of a diffuse large B cell lymphoma that if you don't think beyond beyond the diagnosis, in a wide, with a differential diagnosis, you will miss these cells. So this you can see here. There are large cells with prominent nucleoli, some of which show multilobulation, and you can see some of which show very prominent nucleoli. So these can easily look like mononuclear Hodgkin cells, or even here you can see a smiling cell actually with two prominent nucleoli. So on morphological basis, you can see that this can be confused as a Hodgkin lymphoma. In these cells, just to add to the confusion, it can express CD30. So this is CD30 expressed in some of these cells. But you can see they are it's variable degree of expression, with some larger cells are totally negative for this entity for CD30. And if we can see CD20, it's diffuse. It's highlighting all cell population, all the larger cell, and so this is it's forming sheets of cells. So this is considered as a diffuse large B-cell lymphoma. CD50. It was negative, so that was helpful in determining that this is just a diffuse large B-cell lymphoma. And just to add, the CD45, the PAX5 in this case, it was helpful that these PAX5 show very strong positivity rather than weak positivity, which indicate a full expression of this. So this was a diffuse large B-cell lymphoma. Other differential diagnoses for classic Hodgkin's lymphoma, especially in the mediastinum, are the primary mediastinal large B-cell lymphoma. They usually mature B lymphocytes. They will have expression for CD30, but just focal, and they will be usually CD23. They look like diffuse large classic Hodgkin's lymphoma because they would have stromal sclerosis, but sometimes they express some specific markers that the Hodgkin lymphoma they don't express. And if we look at an example of primary mediastinum large B-cell lymphoma, they can look like a Hodgkin lymphoma. All right, so you will have large nodules, you will have some fibrosis in the background. However, the large cell population, so the population of the cells, they are not typical RS cells, but rather like B cells showing some immunoblastic type morphology. And on immunohistochemical level, they can express CD30. So you can see the expression. But again, as we said, the expression of this CD30 is it's not consistent, is weak, It's patchy with variable staining, mostly weak. And this case was strongly positive for CD20. So this is a primary mediastinal B-cell lymphoma. It was in a young patient. And just this is an added, the PD-L1 expression is very strong in such cases, which an added desirable criteria to diagnose this entity. The other differential diagnosis for classic Hodgkin lymphoma is something that looks like that has features between nodular lymphocyte, nodular sclerosis, classic Hodgkin lymphoma, and primary mediastinal B-cell lymphoma. And this is very difficult, actually. They call it like a mediastinal gray zone lymphoma. They can express CD30, but as we said, it's mostly heterogeneous. The CD15 usually negative in these cases, but it will show some features that will look like a classic Hodgkin lymphoma. And this is, we discourage making this diagnosis on core biopsies unless you don't have any other, because this is one of the core biopsies that we raise the suspicion of this diagnosis, and then we confirm it on an excisional biopsy. But you can see that there will be lots of overlapping features. So you can see so mixed population, mainly histiocytes, as well as small lymphocytes with cells that have a prominent nucleoli. And these cells, they don't show the like expected expression, full expression of CD30. So CD30 was weakly positive in most of the cells. The CD20 was also weakly positive in some of the cells. Let's see. It was expressed in a population of cells, but more than what we can see in T-cell rich, histiocytic rich B-cell lymphoma. And CD15 show very like a negative expression in these cells. If we see here PAX5, so these are difficult cases that they will need like to do a full panel, but you see like a strong expression with some variable expression in some of the background cells, but the background population doesn't look. So yeah, we ended up having a full panel that with features between classic Hodgkin lymphoma and primary mediastinal B-cell lymphoma. So CD45 also was negative in these larger cells. So we ended up calling it a mediastinal gray zone lymphoma. Other diagnoses that you can mix with the classic Hodgkin lymphoma is the nodal T follicular helper T-cell lymphoma, either in angioimmunoplastic type or other B-cell types. They can have lots of reactive B-cells in the background, and they mimic Rh cells. EBV positivity is not uncommon. It can be positive, especially in the angioimmunoplastic type, and can be positive in CD15. However, these the larger cells are strongly positive for CD20 and other T-cell marker. I'll just show the immunohistochemistry of one example of these angioimmunoplastic T-cell lymphoma, or like nodular TFH T-cell lymphomas. They on macroscopic level, they will have that mixed cellularity in the background. They will have high endothelial venules, and the larger cells are the cells that are usually B-cell positive and EBV positive, and the background population is usually T-cell. The CD30 can be positive in a proportion of this larger cell in the background, which will add to the confusion of this picture. I'll just show one example that this one of the TFH marker, that's the CXC13, that's strongly positive in the background T cells. Other differential diagnoses that you are aware of and you should not miss is an anaplastic large cell lymphoma. These cells are usually large cells in the mixed population in the background. The hallmark cells are kidney-shaped cells, but they can form like a full ring of cells, what we call a donut cell. Some necrotic neutrophils or apoptotic neutrophils can present in the background, as well as necrosis with eosinophils. So these cells are this can look like Hodgkin lymphoma, but in comparison to Hodgkin lymphoma, these cells should show strong sheet-like cells, CD30 positive cells. They usually CD45 strongly positive. They usually CD4 positive, as well as EMA. It can be ALK positive or ALK negative. This is an example of an ALK positive case. And the B cell markers ideally should be negative, and PAX, including PAX5 in these larger cells. The ALK negative ones are usually either nodal or extranodal. They will express some of the T cell markers, but some of them they could have like the null type, so they might not express some of the T cell markers, which will add to the confusion. I'll not go into details into this. Just the last thing to mention that peripheral T cell lymphoma NOS can have some CD30 positivity. So just keep it in your mind that screening with 1 or 2 T cell markers can be beneficial in such cases. So this is an example of a case that was diagnosed as a T cell lymphoma with peripheral T cell lymphoma with the CD30 positivity. So you can see the mixed population of the background cells, including neutrophils, apoptotic bodies, histiocytes, but you can see sheets of these large atypical cells. And if we look harder, you look at cells that will look like Reed-Sternberg cells. This one, I'm just showing CD30 just to tell you that CD30 is not a lineage marker. It can be positive in lots of cells, including these cells. So yeah, scattered cells show that pattern of membranous and Golgi pattern type apparatus, and we ended up calling this peripheral T cell lymphoma rather than anaplastic large cell lymphoma because this pass of the CD30 positivity. Ideally it should be block positivity, strong positivity if we're looking at anaplastic large cell lymphoma. And that's it. Now you know a lot about immunohistochemistry, histology, and variants and differential diagnosis of classic Hodgkin lymphoma. I still have the classic, like nodular lymphocyte predominant Hodgkin lymphoma. If I have 5 minutes, I can go through.
Absolutely,
quickly.
yes. Thank you.
All right. So the nodular lymphocyte predominant Hodgkin lymphoma or B cell lymphoma is, as we said, it's a different morphology, different entity. They will withdraw the Hodgkin diagnosis or like word from its diagnosis like soon. It's 3 types of cells. You have the large atypical cells, what we call a popcorn cell, that is multilobulated vacuolated cells. You have background, and these cells show strong positive staining for B cell markers, and this is unlike the other classic Hodgkin lymphoma, can be positive for CD45 as well as BCL6. CD30 and CD15 can be seen, but it's usually negative. And Eber-ish can essentially negative. The CD20 show 2 patterns of staining. So the large cells are strongly positive, as well as there is a background cells, what we call a mantle zone B cells. And these background B cells, they show staining for IgD, CD23, and TCL1 staining resembling mantle zone. And the third component we will have, these are the T cells that will form the background T cells, which are follicular helper cells in immunophenotype that will be essentially positive for CD3, CD4, PD1, and CD45. So how to differentiate between nodular lymphocyte predominant and a lymphocyte-rich classic Hodgkin lymphoma? As we said, CD15 and Eber are negative in nodular lymphocyte predominant. CD45 is usually positive. So, and this is PD1 staining, as you can see here. This is CD20 staining. And the CD21 is a good, I don't have that example here, but usually it shows expanded follicular dendritic meshwork in nodular lymphocyte predominant Hodgkin lymphoma. I'll not go into details on this. But you have to know that there are 6 morphological patterns, and it's dependent on the CD20 availability of CD20. So patterns A to C, it's thought to be better prognosis than D, E, and F. So the first one is, then this is from the WHO book. They have a very good visual pattern type guide. Pattern A is a classical B cell rich type. Pattern 2 is serobinous interconnected B cell rich type as well. Pattern 3 is the prominent extranodal lymphocyte predominant cells. Pattern D is a T cell nodular, so you will have nodules, and within these nodules you will have these LP cells and these rosettes. The pattern E is the problematic one. It's diffused T cell T histiocytic rich large B cell lymphoma-like, or the diffuse large B cell lymphoma-like picture, which is this is the most the one that you need to be know about the most. How to differentiate between these two entities? At least one unequivocal nodule is required to distinguish these two variants. And the presence of background B cells, this is common in nodular lymphocyte predominant Hodgkin lymphoma, these mantle zone B cells, that's usually not there. And the rosettes are, it's something that we see more common in nodular lymphocyte predominant Hodgkin lymphoma. The last pattern is pattern F, which is the diffuse moth-eaten appearance. I will not go into practice cases, but I will just show one last case of nodular lymphocyte predominant Hodgkin lymphoma pattern A. I will show. So this is a lymph node. So you can see the nodularity. You have bands of fibrosis, but not thick bands. And here you see beautiful granulomas surrounding these nodules. And this is very typical for this type. Can happen in classic Hodgkin's, but this is very common in this one. And if we zoom on one of these nodules, you will see that you have like large cells and with a rosette formation of smaller lymphocytes in the background. And this is a typical picture of nodular lymphocyte predominant Hodgkin lymphoma. I'll just show a couple of immunostains. This is CD20. In these larger nodules, you can see the CD20 staining the larger cells as well as the background cells. Maybe here, that's a good one. So the central cells, the surrounding cells are negative, and you have positive background cells. The CD21, this is the type of pattern like slightly expanded follicular dendritic meshwork, and this is the typical feature that you see here. And the last thing I want to show is the CD45. You can see that these larger cells are strongly positive for CD45. CD57 showing some rosettes around these larger cells. So this is how you diagnose. It's just clinical as well. Like it's on morphology alone, you can diagnose this entity. So the take-home message is classic Hodgkin lymphoma is a common disease and could be diagnosed on morphology if it shows classical features. Limited panel as CD30, CD15, PAC5, CD20, CD45 can help confirm the diagnosis. CD30 is not a lineage marker, so it's not, and it can be expressed even in some carcinomas. So just be careful of calling something on CD30 alone. It has to be a panel. Always check the history and the imaging findings, and always be greedy. Ask for more tissue. Basically, excisional biopsies, and try to avoid making bold or rare diagnoses on just limited material. And the context matters. I have a theory that if you stare 30 minutes at a reactive lymph node, you'll start to see RS cells. So just be careful of what your mind games. I think that concludes my talk. If you have any questions, I'm happy to answer. And thank you very much.
Well, thank you very much, Dr. Hussein. I mean, that was like an absolutely fantastic talk. I learned a lot there, particularly the different patterns of nodular lymphocyte predominant. Really excellent mix of kind of like background, science of it, features of each, the morphology, the immunohistochemistry, tips for diagnosis, and also all those differentials, because I think that's a key thing, isn't it? The differentials of Hodgkin's.
Exactly.
There are many things which look like it. One thing I find helpful in distinguishing T-cell histiocyte rich large B-cell lymphoma versus nodular lymphocyte predominant Hodgkin lymphoma is the use of CD21 follicular dendritic cell networks, which
Definitely.
they're seen in the Hodgkin's, but not in the T-cell histiocyte rich.
T-cell.
Yeah. But otherwise, that was the only thing. I don't know if you mentioned that or not. That was the only point.
Maybe I mentioned that earlier. Maybe I didn't. But I didn't
Yeah.
mention it in the key slides. But yeah, definitely. See, absence of CD21 follicular dendritic meshwork, it guides us to the T-cell rich B-cell lymphoma diagnosis.
So that was an absolutely fantastic talk. So I'll be